Think about the last time you got your blood pressure checked. The cuff around your arm, the machine beep, the doctor's glance at the screen, that small nod, and then those four words. Your blood pressure looks good. You exhaled. Maybe you even felt a small quiet pride. You drove home thinking the check engine light was off, that the thing you were vaguely worried about had been looked at by someone who knew what they were looking for, and they had given you the all clear. I need to talk to you about that nod because that blood pressure reading your doctor approved is the most incomplete piece of information you receive during a routine medical visit. Most people walk out of that appointment treating it like it's the whole story. It is not the whole story. A blood pressure reading that your doctor classifies as normal can sit inside a cardiovascular system that is accumulating damage right now, and you will feel completely fine the entire time it is happening. No chest pain, no warning signs, no symptoms of any kind. Just a normal number on a screen and a body quietly working against itself beneath it. And the frightening part is not that this is rare. It's that it is happening to people who have been told repeatedly officially by people with medical degrees that everything is fine. My name is Dr. Michael Kent. I am a cardiologist and internal medicine physician, and I have been in clinical practice for 16 years. I have sat across from patients who did most things right, who checked their numbers, took their medications, showed up to their appointments, and who still ended up in my office facing outcomes that on paper nobody had seen coming. The number looked fine. The cardiovascular system told a completely different story. Today, I want to have the conversation that does not fit inside a 10-minute appointment. There are specific things about blood pressure that every person deserves to understand, not in a way that frightens you, in a way that gives you a genuinely more accurate picture of your own health. When your doctor tells you your blood pressure is normal, here is what they are actually saying. Your reading falls within a range that, when we study large populations of people over time, tends to correlate with lower cardiovascular risk than readings above that range. That is it. That is the complete meaning of the word normal in this context. It is a statistical classification. It is not a biological certification. It is not your doctor looking inside your arteries and confirming the walls are clean, that inflammation is low, that your vessels are flexible and uncompromised. None of that information comes from a blood pressure cuff. What comes from a cuff is a single pressure measurement compared against population data classified accordingly. Most patients hear the word normal and translate it reasonably and understandably as healthy, as cleared, as nothing to worry about. That translation is not what the word means. And the gap between what it means and how it's heard is where a lot of people get into trouble. Let me show you what I mean with two people. Both are 52 years old. Both get a reading of 122/79. By every clinical guideline currently in use, both of them are normal. Both leave with the same reassurance. The first person, call him David, exercises regularly, sleeps consistently, eats mostly whole foods, and has no family history of cardiac disease. His inflammatory markers are unremarkable. His arterial walls show good flexibility for his age. The second person, call him Marcus, is largely sedentary. He carries significant visceral fat around his midsection. He's been pre-diabetic for 2 years. His fasting insulin is chronically elevated. His sleep is poor and largely unresative. His inflammatory markers are elevated. His arteries are already showing early stiffness. And his blood pressure on this particular morning happens to read 122/79. Same number, profoundly different bodies, profoundly different futures. The cuff tells you nothing about which of those two people you are. It gives you a pressure reading. It does not give you a metabolic profile. It does not tell you whether your arterial walls are aging at a normal rate or an accelerated one. All of that is invisible to the measurement, and all of it matters enormously. Most people picture cardiovascular risk the way they picture a speed limit. There's a line. Stay on the right side of it, you're fine. Cross it, and you're in dangerous territory. That is not how arterial damage works. Arterial damage is not a switch, it's a dial. And that dial is always turning in every person at every age, regardless of their blood pressure reading. The question is never whether damage is occurring. The question is always at what rate. Picture sun exposure. UV radiation does not begin damaging skin cells at some specific threshold of sunlight. Cellular impact is happening across the entire spectrum of exposure. What changes is the rate, the intensity, and the accumulation over time. Your arterial walls work exactly the same way. Even someone with genuinely excellent blood pressure, 110/70, maintained consistently for 30 years, is still experiencing gradual microscopic changes in the structure of their vessel walls over time. What excellent blood pressure does is slow that process in research models by a factor of 5 to 10 compared to someone running consistently elevated. Someone maintaining a blood pressure of 142/90 for 15 or 20 years is experiencing microinflammation at the endothelial lining at a sustained level that progressively compromises the vessel's ability to regulate itself. Gradual loss of arterial elasticity. Gradual reduction in the cardiovascular system's ability to respond to stress, to exercise, to the ordinary demands of daily life. And none of this produces symptoms. There is no pain signal from an artery losing elasticity. People feel completely fine while their vascular system is aging at an accelerated rate beneath a number their doctor nodded at. The damage doesn't announce itself, it accumulates. And then one day, after years of silent accumulation, the system reaches the point where it cannot compensate anymore. And that is when someone calls an ambulance. Now, here is what makes this conversation more uncomfortable and more important. The guidelines your doctor is following to evaluate your reading. Those guidelines are not agreed upon, not even close. Right now, the American Heart Association, European cardiology bodies, and several independent clinical guideline committees around the world are all publishing different blood pressure targets, and they disagree with each other in ways that have direct, concrete consequences for individual patients. The AHA guidelines, the most aggressive currently in use in American cardiology, push for systolic readings below 130 and for certain high-risk patients below 120. This is based significantly on a landmark trial called the SPRINT trial, which showed that keeping systolic pressure below 120 was associated with reduced cardiovascular events, stroke, and all-cause mortality. On the surface, that sounds like settled science. Lower is better. Get everyone below 120. But read the full SPRINT data, and a more complicated story emerges. A significant portion of patients in the intensively treated group experience serious side effects: dizziness, episodes of near fainting, chronic fatigue. And in older patients, those in their 60s, 70s, and 80s, those side effects are not minor inconveniences. They are fall risks. A 74-year-old patient who becomes dizzy standing up too quickly is a patient who can go down on a hard floor, fracture a hip, sustain a head injury, and be hospitalized for a cascade of complications that began with a blood pressure medication that was technically following evidence-based guidelines. European guidelines, by contrast, tend to target below 130 to 140 depending on age and individual risk profile. For a 67-year-old patient, that difference in target could be the difference between being on medication and not being on medication. Same patient, different continent, different guidelines, different treatment. I use guidelines every single day. But there is a difference between using a guideline as a starting point for a clinical conversation and using it as a final answer applied uniformly to every person who walks through the door. Over the course of my career, I have taken more patients off statin medications than I have put on them. Sit with that for a moment. Coming from a cardiologist, these are drugs prescribed specifically to reduce cardiovascular risk, the core pharmacological tool of my specialty. And I have spent more clinical energy removing them from patients' regimens than adding them. Here is what I kept seeing. Patients, particularly patients over 65, who had been on statins for 2, 3, 4 years, coming in with family members who were worried he's not himself. Her memory isn't what it was. In a significant number of those cases, when we carefully tapered the statin under close monitoring, the cognitive fog lifted, the sharpness returned. Family members described feeling they had their person back. My father was one of those people. He was a retired structural engineer, meticulous, methodical, sharp in his early 70s, in a way that made you forget his age entirely. When he was 72, a mildly elevated cholesterol panel led to a statin prescription. A good physician practicing well within standard guidelines, looking at a number and making an evidence-based decision. Over the following 18 months, my father changed slowly. At first, he'd lose the thread of conversations in ways he never had before. He'd ask questions he'd already asked 20 minutes earlier. He started having difficulty with tasks that had been second nature to him his entire adult life. By the time I made the connection, by the time I recognized in my own father the same pattern I had watched in my patients, 2 years had already passed. 2 years we didn't get back. We worked with his care team to reduce and eventually discontinue the medication. Some of what he lost came back, not all of it. I am not making a blanket clinical statement that statins cause cognitive decline in all patients, or that no one should take them. There are patients for whom statin therapy is genuinely, unambiguously life-extending, and I prescribe them without hesitation. What I am saying is that for a subset of patients, particularly older adults, aggressive lipid reduction carries cognitive costs that do not show up in the headline outcome data. The number gets treated. A different column does not always get measured. I tell you that story because the most important medicine happens when a doctor stops talking about patients and starts talking about people. Physicians practicing inside large health systems are evaluated in part on quality metrics. One of those metrics is the percentage of their hypertensive patients whose blood pressure readings fall within guideline-specified ranges. If a doctor's patient panel is not hitting those benchmarks, it registers in their performance data. It can affect compensation. It creates real institutional pressure to get the number into the acceptable zone efficiently. The result is that the appointment can end up being about the number on the screen rather than the person sitting in the chair. So what can you actually do about that? Ask specific questions. This is not confrontational. It is collaborative, and it is the single most effective thing a patient can do to shift the dynamic of a medical appointment towards something genuinely useful. Ask your doctor, given my overall metabolic picture, my weight, my insulin levels, my inflammatory markers, my sleep quality, is blood pressure the most important number we should be tracking right now? Or are there other measurements that would give us a more complete picture? Ask, if I made specific, consistent lifestyle changes over the next 90 days, what would you realistically expect to happen to this number and to my underlying cardiovascular risk? Ask, if I'm currently on medication to achieve this reading, is that the same level of protection as someone who achieves this reading naturally? That last question is the one I want to dwell on, because the answer will likely surprise you, and it leads directly into the most important thing I'm going to tell you today. 2 patients, both women, both 58 years old, both come into my office and the cuff reads 124/80. By every standard clinical guideline, both of them are normal. Both receive the same reassurance. Here is the difference. The first woman, call her Carol, has been on 2 blood pressure medications for 7 years to achieve that 124/80. Without those medications, her readings run consistently in the 158 to 165 systolic range. She takes her medications faithfully. Her number looks excellent. She has been told her pressure is controlled. The second woman, call her Diane, takes no blood pressure medications. She has maintained a 124/80 naturally. She exercises regularly, sleeps well, eats largely whole foods, and her inflammatory markers sit in a healthy range. Same number on the cuff. Which woman carries higher cardiovascular risk? Most people pause when I ask that. The number is identical. Carol's medication is clearly doing its job. Surely the risk is equivalent. It is not. Carol carries meaningfully higher cardiovascular risk than Diane despite the identical reading. And here is precisely why. When blood pressure has been consistently elevated for years, the cardiovascular system undergoes real structural anatomical changes. The heart, which has been working against elevated resistance for an extended period, begins to adapt. The left ventricle, the main pumping chamber, thickens and stiffens over time. This is called left ventricular hypertrophy. And that structural change does not reverse simply because a medication brings the pressure reading down. The arteries tell the same story. Vessel walls that have been exposed to years of elevated pressure develop reduced elasticity, early plaque formation, increased stiffness, and compromised ability to dilate and respond to demand. Those changes persist in the vessel wall. The medication suppresses the pressure measurement. It does not rebuild the vessel architecture. The medication is doing something genuinely important. It is reducing the ongoing pressure load on a cardiovascular system that needs that reduction. That matters. That is worth doing. But it is not returning Carol's cardiovascular system to the biological condition of someone who never had elevated pressure to begin with. It is managing the present. It is not erasing the history. And that history encoded in the structure of her heart muscle and arterial walls is what keeps her risk elevated above die-ins. Picture two houses on the same street, built the same year, same square footage, same exterior. From the curb, they are indistinguishable. The first house has stood without incident for 30 years. Sound foundation, good structure throughout. The second house experienced significant water damage 8 years ago. The damage was repaired, the walls were repainted, the floors were replaced. From the curb, from every visible measurement, it looks identical to the first house, but inside the walls, underneath the new paint, in the joinery and the foundation, the second house carries the history of that event. It is more vulnerable to the next stressor. The repair addressed the visible problem. It did not restore the original structural integrity that is Carol versus Diane. The measurement looks managed. The biology is not. If you are taking medication that is keeping your number in range and you are eating in a way that drives chronic insulin elevation and you are sleeping poorly and you are carrying unmanaged visceral fat and you are largely sedentary, your medication is holding down a reading while the underlying conditions that drove that reading continue to operate, continue to accumulate, continue to modify your vascular system in ways the cuff is not capturing. The number looks controlled. The biology underneath it is not being addressed. Conversely, if you address the underlying drivers directly, if you genuinely improve your metabolic health and manage the lifestyle variables that determine your vascular environment, you are doing something that medication fundamentally cannot do. You are not suppressing the measurement. You are changing the conditions that produce the measurement. The medication manages the number. The lifestyle changes the biology. Only one of those addresses the actual problem. Normal is a population word. It describes where your reading sits, relative to a statistical distribution. It tells you almost nothing about the metabolic environment that reading is sitting inside, the history your vascular system has accumulated, whether you arrived at that number naturally or pharmacologically, or what your arterial structure looks like beneath a reassuring cuff measurement. Two people can have the exact same number and face profoundly different cardiovascular futures. The person who understands that, who walks into their next appointment asking better questions, who treats the underlying metabolic environment rather than only managing the surface measurement, that person is not just treating a number. They are treating themselves, which is the only thing that was ever worth treating in the first place. There is one more piece of this conversation we haven't touched yet, and it contradicts something most people have been told their entire adult lives about managing blood pressure. Most people have been told that sodium salt is the primary dietary driver of elevated blood pressure. Reduce your salt, protect your heart. That recommendation has been repeated so consistently for so many decades that almost nobody questions it. The research tells a more complicated story. What the data actually shows about what is driving vascular pressure at the cellular level, about the role of processed carbohydrates, chronic insulin elevation, and the mechanism by which the kidneys regulate fluid volume and arterial tone will change the way you think about every dietary recommendation you have ever received. That is the next video. If this conversation gave you something useful, if it changed the way you're going to think about your next blood pressure reading, your next appointment, or the medication you've been taking without asking the right questions, share this video with someone who needs to hear it. Particularly anyone you know who is on blood pressure medication and believes that because the number is controlled, their risk is controlled, that conversation could genuinely matter for them. Subscribe so you do not miss the next video, because what we cover there, the insulin connection, the sodium research, the actual upstream drivers of blood pressure at the cellular level, is where this information becomes actionable. Leave your questions in the comments. I read them. I'm Dr. Michael Kent. Thank you for giving me your time today. Take care of yourselves.